Chapter 49: Pituitary, Thyroid, Parathyroid, and Adrenal Disorders. The pituitary gland, located in the anterior lobe. This is where the production and the majority of the hormones from the pituitary gland are secreted. This would include things like growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, FSH, and luteinizing hormone that you'll no doubt be speaking about much more in your OB modules. Case of adrenocorticotropic hormone, ACTH. This stimulates the release of things like cortisol, aldosterone, and androgen. And there are drugs to diagnose adrenal insufficiency, such as corticotropin. There's also prolactin that works to stimulate the breast tissue for milk production, and drugs related to prolactin excess. The pituitary gland in the posterior lobe. In this area is where ADH, antidiuretic hormone, and oxytocin are secreted by the posterior pituitary gland and the hypothalamus. In the case of antidiuretic hormone deficiency, this is where you get a condition called diabetes insipidus. While it has diabetes in the name, it is not related to blood sugar. In this case, the kidneys are unable to not excrete water, and all the water that hits that kidney is immediately flushed out. Large amount of water is secreted and leads to fluid deficits and electrolyte imbalances. Because again, it's not just flushing out the water, it's also flushing out all of those electrolytes as well. On the opposite end of that, an excess of antidiuretic hormone. In this case, the kidneys have too much of that hormone and they're not excreting any water, and the patient can quickly become fluid overloaded. Drug therapy for anterior pituitary disorders, specifically growth hormone deficiency. In this case, somatotropin would be used to treat a growth failure, and corticosteroids can be used to inhibit the effects of somatotropin. This would result in side effects such as paresthesia, arthralgia, myalgia, weakness, and cephalgia. Gigantism. This is a condition, just like it sounds, where excessive growth hormone is produced in childhood. It can also result in acromegaly, where excessive growth hormone after puberty. Some drugs used for this are going to be octreotide. Other drugs for anterior post-pituitary disorders would be cosyntropin. This is a synthetic ACTH and approved only for diagnostic purposes. It's less potent and less allergenic than corticotropin. Corticotropin is primarily used to diagnose adrenal gland disorders, treat multiple sclerosis, and infantile spasms. It's rarely used for corticosteroid responsive disorders. In the case of treating posterior pituitary gland disorders, antidiuretic hormone preparations such as vasopressin can be administered intranasally or by injection. These are going to be contraindicated in patients with moderate to severe renal disease and in patients with hyponatremia. Side effects would include things like hyponatremia, dyspepsia, diarrhea, nausea, and vomiting. The therapy for syndrome of inappropriate antidiuretic hormone would be treated by fluid restriction, as well as hypertonic saline. Pituitary hormones. Again, we're going to be focused on hormonal regulation, treating the underlying cause. While we're doing this, we would be also carefully assessing patients' fluid status, hydration, as well as electrolyte balances. When dealing with pituitary hormones, we want to carefully monitor vital signs, record urinary output, obtain daily weights, and monitor the blood glucose and electrolyte levels. The thyroid gland. This is one you're going to hear and deal with a lot. It's an important regulator for many of the bodily functions, and the three hormones produced are going to be T3, T4, and calcitonin. These are negative feedback mechanisms that regulate hormone secretion of the thyroid gland. One common NCLEX question you're going to get when it comes to endocrine and these hormones is that you'll see an elevated level of TSH with low levels of T3 and T4. And you'll see an elevated levels of T3 and T4 with low levels of TSH, because that TSH is the thyroid stimulating hormone. And when the thyroid hormones themselves are out of whack, in the case of it being low, the body's producing all this TSH to try to get T3 and T4 produced. But unfortunately, the thyroid is unable to produce that and respond. Hypothyroidism. This is a decrease in thyroid hormone secretion, primarily decreased T4 along with those elevated TSH levels. And it's due to acute or chronic inflammation of the thyroid gland, radioactive iodine, an excessive intake of antithyroid drugs, or it could be secondary to a lack of TSH secretion. Hyperthyroidism. In this case, we have too high levels of our T3 and T4. And again, that's going to correspond with a low level of TSH. It results from an overactive thyroid gland or excessive output of thyroid hormones. And in this case, we're going to be looking at conditions like Graves' disease. It's going to be characterized by big bulging eyes, along with weight loss, tachycardia, nervousness, irritability, and heat intolerance. When treating hypothyroidism, we're going to be looking at levothyroxine, Synthroid. This is a synthetic thyroid hormone. It's the drug of choice for replacements and also treats things like simple goiter and chronic lymphocytic thyroiditis. Hyperthyroidism. This includes antithyroid drugs that inhibit either the synthesis or release of thyroid hormone, such as propylthiouracil. These control overactive thyroid due to Graves' disease, toxic nodular goiter, and are used prior to radioiodine treatments or thyroid surgeries. Again, anytime we're giving any of these thyroid drugs, we want to carefully check the three levels, T3, T4, as well as TSH. Encourage the patient to take the drug at the same time each day in relation to their meals. Also teach the patient to check any warnings on over-the-counter drug labels and suggest the patient carry a medical alert identification. They should also be aware that food can interfere with thyroid hormone absorption. The parathyroid gland. This secretes parathyroid hormone and works in a negative feedback, working with serum calcium to stimulate the release of PTH. Parathyroid hormone enhances calcium release from bones. It also enhances calcium reabsorption in renal tubes. It also enhances calcium absorption in the intestines by increasing production of vitamin D. And you're going to see that parathyroid hormone, calcium, and vitamin D are all closely linked together. Hypoparathyroidism. This is caused by things like parathyroid damage, hypomagnesemia, hypocalcemia, vitamin D deficiency, renal impairments, and diuretics. PTH replacement helps correct the calcium deficit and treated with things like calcitrol, calcitone and salmon, or calcimimetics used to lower the serum calcium. Hyperparathyroidism. This is an excess parathyroid hormone secretion due to usually malignancies of the parathyroid gland, ectopic PTH hormone secretion from lung cancer, hyperthyroidism, or prolonged immobility. We want to carefully look at both the parathyroid hormone levels, but also the serum calcium levels, along with the vitamin D levels. Monitor the serum calcium level, and any calcium below 8 indicates hypocalcemia. And total serum calcium greater than 10.5 indicates hypercalcemia. Calcium's going to be a lab level that varies depending on the textbook, depending on the hospital, even depending on the unit you're in. While it's an old acronym that used to be Cal 911 for calcium 9 to 11. Call 911 was the acronym. Though be aware that many different ATI your text are going to vary slightly on this. It's just a good judge to get you pretty close. The adrenal glands. The adrenal medulla produces epinephrine and norepinephrine. The adrenal cortex produces glucocorticoids and mineralocorticoids. Glucocorticoid hyposecretion. In this case, we're talking about Addison's disease. And you can remember Addison's is low adrenal. Addison's adds some. On the other end of that is going to be Cushing's syndrome. That's hypersecretion of those adrenal hormones. Glucocorticoids. These are the most potent natural cortisol produced by the body. In this case, we can mimic that with drugs like prednisone that affects inflammatory response, growth, and biorhythms, affect carbohydrate, protein, and fat metabolism, as well as affect muscle and blood cell activities. Used in a wide variety of conditions, everything from traumas, surgeries, anxiety, inflammation, ulcerative colitis, allergic conditions, and even preventing organ rejection. Keep in mind the patient should taper off gradually. Side effects would include things like euphoria, psychosis, thin skin with purpura, tachycardia, hypertension, edema, adrenal atrophy, muscle wasting, abnormal fat deposits, peptic ulcers, and growth retardation. Mineralocorticoids. These promote sodium retention along with potassium and hydrogen excretion. An example would be fludrocortisone. This works to promote sodium retention, along with promoting hydrogen ion and potassium excretion. Used in cases of adrenal cortical insufficiencies, it's going to have some side effects ranging from negative nitrogen balance, fluid imbalances, hypokalemia, hypertension, fluid overload, and GI distress. Hormonal regulation, that's going to be the name of the game when we're dealing with corticosteroids. We want to carefully monitor baseline vital signs for future comparisons, looking at lab results with a key focus on electrolytes and blood glucose. Corticosteroids, these, again, lab values, vital signs. Watch for any evidence of hypokalemia. Assess for side effects of corticosteroids. And monitor older adults for any evidence of increased osteoporosis. For our first practice question, a patient has adrenocortical insufficiency and was taking hydrocortisone 240 milligrams every 12 hours. Before discharge, the patient was switched to prednisone. Which is appropriate teaching for discharging a patient with oral prednisone? Would that be A, stop the drug when feeling better? B, prednisone is always given by injection? C, the dose needs to be tapered off over 1 to 2 weeks? Or D, hyperkalemia is common? And that answer is going to be C. The dose needs to be tapered off over 1 to 2 weeks. Never stop prednisone abruptly. A nurse has been teaching a patient about levothyroxine, Synthroid. Which side effect should the nurse teach the patient to observe for? Would that be A, somnolence, B, bradycardia, C, constipation, or D, nervousness? That answer is going to be D, nervousness. Practice question 3. The nurse will teach a patient taking levothyroxine for hypothyroidism to notify the healthcare provider if he or she experiences which of the following: A, dizziness, B, nausea, C, palpitations, or D, abdominal cramps. That answer is going to be C, palpitations. Question 4. During a diagnostic test for parathyroid function, a patient asks the nurse what the parathyroid gland does. The nurse correctly informs the patient that the parathyroid gland is responsible for which of the following: A, regulating the body's metabolism, B, maintaining blood glucose levels, C, controlling the release of glucocorticoids, or D, regulating calcium levels. And that answer is going to be D, regulating calcium levels. Question 5. Which drug would the nurse administer for the treatment of a patient with hyperthyroidism? A, liothyronine sodium, B, methimazole, C, Liotrix, or D, thyroid? That answer is going to be B, methimazole. Practice question 6. The nurse identifies which of the following is the drug of choice for the treatment of chronic lymphocytic thyroiditis. This is Hashimoto's. This is an autoimmune condition that attacks the thyroid. Would that be A, liothyronine, B, levothyroxine sodium, C, propylthiouracil, or D, methimazole? And that answer is going to be B, levothyroxine or Synthroid. In this case, Hashimoto's is that autoimmune condition that's attacked the thyroid and it's no longer able to produce thyroid hormone of its own, so we're giving it synthetically. And for our final question, a patient has hypoparathyroidism. The nurse anticipates administration of which medication? A, midotane, B, fludrocortisone, I hate that word, C, dexamethasone, or D, calcitriol? That answer is going to be D, calcitriol. But anyway, that's all we got for this chapter. I'll see you in the next slides.